much, gentlemen. And thank you for inviting me. I'm Angela. Most people around the world actually know me as Angela. So if there are other Angelas in the room, you got to wait till I'm done. I am going to give you an update on clinical trials. I actually have met a lot of you over the years, and you're doing a phenomenal job, a really phenomenal job. So I consider this as a partnership and a team. My patients are always the first part of the team, but you guys are really integral to our team. So I just want to let you know that in our clinic, ALS Quebec sits with us. They're back. We had a little tough time with COVID because we had to fight to be able to see our patients. And in fact, we continued at the neuro in-person visits throughout COVID. We were very fortunate. We found a respiratory therapist who was working on our clinical trials, who did the pulmonary function test for us in the right controlled measures. And now finally we have our ALS Quebec team with us. So with that, I'm going to start. I'm going to give you an update. It's titled Outcome Measures in Clinical Trials, but I want to give you a bigger update than that, but well within my 20 minutes, I promise. First, my disclosures. I'm putting up a slide for both Colleen and I. So just to make sure it's a joint disclosure slide. Pick and choose which companies you want me to talk about. Here's where the money is. And I really mean the money. This is a wheel. Can you guys all see it? Yeah. This is a wheel of how many drugs there are in development. Okay? So if you are in a clinic and you have not been offered a clinical trial, there's something wrong. So these drugs are not in every clinic, and there's a reason for that. It's not punitive. It is that certain trials require more setup, if you were. You need to have a phase 1 unit. You need a bit more sophisticated setup. And other trials are actually much easier if you are a smaller clinic, if you are a clinic that just wants to get into clinical trials, and I'll get to that at the end. Don't let me forget that. There are trials that you can do. Some patients get frustrated by some of the limitations in inclusion and exclusion criteria in clinical trials. And I'm actually ask those of you who get frustrated to bear with us. We're not, again, doing this on purpose. We're doing this so that we can prove as quickly as possible that a drug is working so that we can get it out there for all patients. So there are a lot of nuances in clinical trials that do affect your participation, but you should never not be offered a clinical trial, in my opinion, if you are in an ALS multidisciplinary clinic. The other part of this wheel is the number of targets. On the outside, I think there are targets like oxidative stress, some genetic targets, some non-genetic targets that are being handled using genetic type therapies. That really is a culmination of all the researchers that you guys support with your national association. So I consider the basic science researchers a really big partner here, because they're the ones that come up with the ideas that lead to a therapeutic. So I think we're all in this together. But this just is to give you an idea. Things are moving, things are shaking, and it's really important that we're all together and working in this, moving in the same direction. To give you an idea of how important ALS clinical trials and drug development have become, I want to just highlight this really important thing that passed through Congress. Now, I'm Canadian, so I really shouldn't know this much, but Canada lives next to the US. And we're like, the US gets a cold, we get pneumonia. That really is what happens. But this act is actually one of the really positive things. Now, don't kid yourself. This is a massive political act that we have here in the U.S. And there will be lots of people lobbying for this money. And what I've seen over the years is that when something is tagged for ALS, all of a sudden people who have nothing to do with ALS come up with programs to get at the money. But we do have this initiative, and it's really important. And it's actually important for what I'm going to talk about at the end, which is biomarkers and outcome measures for clinical trials. Because buried in this is support from the FDA to groups to improve and refine our outcome measures and biomarkers. So this is good. There are difficulties. These difficulties aren't going away. I present this slide to a lot of different people on purpose because we really, as a clinical trial community, need to get better at this. I'm very proud of a couple companies that I worked with in the last 5 years for actually helping on this. So biomarkers are changing. The top bullet is a lack of sensitive biomarkers, but I can tell you that that's changing in real time. I'll address that in a little bit. But now every one of the high quality clinical trials that I see has some version of a biomarker included. And that's really important for us, again, to help speed up this development. Publication of negative results, that's what I was really leading to. There are 2 different big programs, and both companies are actually going to publish their negative results. And that's a big deal for us, because that's how we get that information integrated into our next clinical drug development program so we don't make the same mistakes. The next step is to get all of the data from the placebo arms of clinical trials into PROACT. I think PROACT is now under ALSA. I don't quite understand how the structure is now, but I'm a big proponent, and I can honestly tell you I tackle every company that's in this field that if they finish a clinical trial, they're obligated to put that placebo data into PROACT, because that's how we model our next clinical trial. And if you're modeling your clinical trials in 2023 on data from 2010, your model may not be good enough. So if any of you have influence, please continue to push companies. Difficulty identifying small clinical changes, I'll talk to that more. And one of our big things, which is in the little graph, is the diagnostic interval. So the time from symptom onset to diagnosis and referral to an ALS center. We have an extraordinarily big problem in Canada. We have it, and the big problem in Canada is your ALS care and your referral time to a clinic is completely based on where you live. And Canada shouldn't have that level of inequity. If you live in Quebec, you can get diagnosed in 3 months. If you live in some other provinces, it can take 1.5 to 2 years for a diagnosis and referral. Well, if you know anything about clinical trials, if you're not given your diagnosis and referral till 18 months, you've just missed every clinical trial out there. And it's not your fault, right? So everyone is in on that part as well. I can tell you patients have been a big part of the scene in Quebec. We've had patients regularly go public early in their disease. And so the level of awareness of an entity like ALS is very high in the medical community in Quebec, and in the patient community as well. But really, we need to get this done. Otherwise, we really are going to struggle. Negative RCTs, a big problem, mostly in getting some of the trial design issues worked out. I'm going to just mention this in passing. The US is not the only country that's putting money into ALS. The UK, I'm so proud of my colleagues, a little bit envious. I might move there, I don't know. They've got Boris Johnson, of all people, to sign a document before he left office that commits them to, I don't know, somebody in the room can tell me, is it 20 million, 15 million? 15. 15?
50.
50 million pounds Okay, we're all moving to the UK. But this is fantastic, and it speaks to really partnerships, which I mentioned at the beginning. So why am I an optimist, other than the fact I was born an optimist, so you can't beat that out of me even now. I'm an optimist because things are changing faster than they ever have. And they're changing for a variety of reasons. One of the really important things that I say when I talk to all sorts of people, particularly regulators and also colleagues, is ALS is the equivalent of pancreatic cancer, right? Same lifespan, may have different symptoms, same difficulty treating it. So let's treat ALS patients like they have pancreatic cancer, get them into protocols, get those biomarkers moving. And some people are starting to hear it. On the list of companies I had up there in the beginning, every one of them have now integrated biomarkers and ways of seeing early signal into their programs. And I think that's fantastic. So what are biomarkers? Very, very briefly, biomarkers are ways to measure the effect of a drug before there is a clinical measurement or at the same time. Why are biomarkers so important? Because we don't yet have a way clinically of saying whether a drug works before we have a fairly significant change in function. And so if you have a biomarker that indicates that you are having a positive effect, then you can look at a drug, you can extend a protocol, you can get more data, and you can use it in your application to get approval with the regulator. So big deal. They can be used at multiple different phases. And the biomarkers can help choose the dose. They can help determine safety that you can't see clinically. And certainly these days, they're starting to help speed up approval. It's the beginning of a change. I have a bit of MS envy. I call it MS envy. Because the MS community didn't even have to work to get their best biomarker, which is MRI. They lucked into it. All of the physicists developed in magnetic resonance imaging, and some really smart radiologists said, oh, what are those UBOs? Because that's what they were called. Unidentified bright objects, and that is what changed the game in MS in the 90s, and we're looking for the equivalent. So is neurofilament the equivalent? It might be. Neurofilament is a marker of disease activity because it's a marker of neurodegeneration, particularly degeneration of motor neurons. It is a well-known protein. This is not new news. What's new is that neurofilaments have now, there have been enough observational studies, and thank you to every patient who's agreed to have an LP or a blood draw to help build this body of evidence. But the evidence is now very clear that neurofilament light by a certain technique called Simoa and neurofilament heavy and light in the CSF are indicators of disease, and in fact now are being considered indicators at the beginning or at the time of diagnosis of actually how quickly your ALS may progress. And that becomes really important for us because it gives us a way to measure improvement by showing a change in the level of neurofilament. The next one that I'm going to mention briefly again is the biomarkers that are more specific. Okay, so another one of my stories, very quickly. 10 years ago, you whispered to a patient that you may have familial ALS. It was considered really difficult to tell a patient that you may have ALS and you want to do a genetic test. Since 2015, I'm going to say it was 2015, we at the Neuro have been doing genetic testing on every patient diagnosed with ALS. Why? because that's where drug development has moved the most quickly. That's where we've got a really dramatic response with tofersen. And why would you not try to find every patient with SOD1 now that we have this drug around? This is going to get more and more and more important, and the data out there suggests that at least 20%, and I may be making, it may be a lowball figure, of patients who are called sporadic ALS have a genetic mutation. So big deal, important for drug development, not a biomarker or an outcome measure, but it changes the game because we have better treatments for that. And these biomarkers, misfolded SOD1, a total SOD1, poly-GP, we're going to have some for Stathman, we're going to have some, there's a biomarker for the FUS program. These are really important. What else can we use for biomarkers? And again, those of you who are being offered clinical trials, some of these things may seem off-putting to you. They're critical to us. I mentioned LPs. I'm mentioning now electrophysiology. There are now techniques in EMG that we can use, such as M-scan, that actually help us to determine if the drug has hit the target. So we can more quickly determine whether we should keep developing this drug to get it available to everybody. We have other techniques in electrophys that are going to help us look even at neuromuscular junctions, so really big deal. This friend or foe, the ALS-FRSR, some call it a friend, some call it a foe, I just call it a problem, is here to stay. We are working on better things. It is true that it does not meet all of our needs. However, we have so much data on it that it will continue to be in clinical trials, but maybe be less, control less the results of the trial. But the reason it's going to stay is we have these used data sets that we use for modeling for our trials. What we're doing with it is to make the process of administrating the ALS-FRSR in clinical trials more robust, less variable, because we've discovered that if two different raters in a clinical trial do the ALS-FRSR, the score can change by 4 points on the same patient. Well, that throws all your statistics out the window. So we're looking at a bunch of things, and I'm going to mention one more thing about this, and there are two different people working on improvements in the ALS-FRSR. One job I've already done, I've gotten the Europeans and the Americans to talk to each other and actually harmonize their training program. That's big. The second, which I'm going to mention in a half a minute, is patient-reported ALS-FRS. And I don't mean a coordinator calling a patient and documenting it. That keeps that coordinator-related variability in the program. I'm talking about something that both James Berrien in Massachusetts and Andre Meyer in Germany have developed, and that is a way of patients administering their own ALS-FRS and recording it as part of clinical trials. Why that's important is the variability really goes down. So your data actually is more robust. And the reason it's more robust is whatever bias the patient has who's in the clinical trial, that bias stays for the whole of the trial. So if they consistently rate themselves higher, they consistently through the whole trial. Whereas when you change raters who are not the patient, even if it's done over the phone, their inherent bias starts to enter, and that's where the variability comes. There are lots of adaptive trial designs. I'm not going to go into it, but just to say, when you hear the idea of an adaptive trial design, or if somebody says a trial is going to be ongoing, that's a good thing. What we're doing is leaving out the gaps between phase 1 and phase 2, and phase 2 and phase 3, and really creating trials that once you start the trial, it keeps on going. This is tofersen. I'm not going to go into it. It's a great example of an adaptive design. And one last thing that I want to mention, and that is open label extension studies. Now, some people think open label extension studies are the equivalent of special access programs and EAPs. They're not. Open label extension studies are what have gotten the last 2 drugs approved over the finish line and are probably going to help tofersen in the same way. They are robust ways that we continue to give drug to patients who participated in the clinical trial, and we continue to get the data. And that data is what is making the difference in front of the regulators. So if you are in a clinical trial and they talk about the open label extension, please go into it. That data may be the difference between approval and non-approval. And if non-approval of a promising drug happens, then a whole other clinical trial has to be done before everyone gets access. Neurofilament, clinical function, the good, the bad, and the ugly. What's good? What's good is we're using biomarkers. There is a consensus around NFL. There will be a consensus around other things. We've harmonized the Americans and the Europeans. We still need to bring in Asia to make sure their training is the same. We have alternatives to the ALS-FRS. The roads from Georgia from Atlanta is really moving forward. Adaptive designs are here to stay. OLEs are a part of it. I consider them obligatory, and I tell the sponsors that. Many drugs are in development. What else do we have to do? We have to put the statisticians all in one room. That's my next job. I have to find every statistician working on ALS and put them in one room, because they've got to stop using different analysis plans that confuse everybody and don't help the field. And then finally, and this is a pet peeve of mine, and people may disagree with me, and I can handle disagreement. Social media is fantastic. It's how we recruit, how we tell everybody what we're doing. I encourage sponsors to use vetted social media when they're starting their trials, and I think it's a very powerful tool. I do not like the abuse that has happened in the last few years on social media when people are unhappy with outcomes. There are reasons behind what is done in drug development. It is not, people are not trying to be difficult. And so I ask people to take a breath before you send a tweet. Just take a breath, because you may not know everything that's going on. And what we really want to do is get over that finish line, hit a home run for every ALS patient. Right now, we're hitting a home run maybe for SOD1 patients, and I have seen things I've never seen before with tofersen. We have a huge potential with FUS patients, and we have a second drug for SOD1 patients. And we have all of these other super exciting drugs coming, but let's do it together. Let's not attack each other. Let's do it together. And with that, I'm going to show you my team. We're somewhere over 60 now. Well, it's the United Nations, as you see. We speak multiple languages. We take patients from every country, and that's just a step until we can get clinical trials set up in every region. Absolutely. And with that, I'm going to say thank you. I probably went over 2 minutes, but that's not bad for me. Thank you.
Thank you, Angela.